physician, he's a consultant at Southampton, and did a fellowship in andrology at the Institute. In fact, followed me.
I'd forgotten that, but yeah, a long time ago.
A long time ago.
Yeah, so contentious, I couldn't find anybody else to speak on this topic, so I had to ask myself in the end, and so here we go. A quick run through the issues around testosterone and prostate cancer. So the issues I wanted to talk about is, just to spell it out really, the link between testosterone and the prostate, the link between testosterone and prostate cancer risk, and then finally a little bit on testosterone therapy and prostate cancer. So what does testosterone do? Well, it has various actions with various means. It has direct actions on the bone and on potency, etc. It's reduced by 5-alpha reductase to DHT, as we well know, which has actions within the prostate itself, and it can be aromatized to estradiol, which has effects on bone, psychotropic actions, lipids, etc. So a number of methods of action, and it can act genomically, non-genomically via the androgen receptor, or indirectly, as I say, via DHT or estrogen, and some non-classical routes as well, including G protein coupling, etc. So quite a complex situation, not a very simple linear situation. And the androgen receptor may well be relevant, particularly with differing responses. We see patients, strangely, some with very low testosterones who are apparently very fit and well, and other men who've got borderline testosterones and are highly symptomatic. And there is some polymorphism of the androgen receptor based around the CAG repeats at the end of the end terminal of the androgen receptor here, which is polymorphic and therefore potentially accounts for some of the variability in responses to testosterone and testosterone levels. Therefore, what about BPH? The prostate itself, androgens necessary for BPH, but they're not causative. So they appear to have a permissive action rather than a directly proportional action. And of course, we're well aware that there are many other mechanisms theorized as to what the etiology of BPH, including nitric oxide, the autonomic nervous system, Rho kinase, ischemia, etc. So again, not a simple situation, and particularly men on testosterone replacement therapy do not necessarily see a worsening of prostate volume or increasing prostate volume or indeed symptoms. What about natural history? So this again fits really. So with age, both testosterone, free testosterone, and total testosterone fall, yet the rates of BPH and the prostate volumes go up over time. And this study by Rastrelli and Giovanni Corona's group from Italy, published a few years ago, basically correlated testosterone levels to PSA and found that there was a saturation point, and there, again, it's not a linear increase at around 8 nanomoles per liter, further backing up this theory. And that led Morgenthaler to talk about the saturation theory. Here's a study from Jeff Hackett, who gave testosterone therapy to sort of high-risk group diabetics who had hypogonadism. And amongst some other interesting studies, including a reduction in mortality, a significant reduction in mortality, they showed that in the low testosterone group, or the severe hypogonadal group, testosterone of less than 8, that there was only an increase of 0.5 in the PSA over the course of the study. And in those who had sort of mild hypogonadism, between 8 and 12, there was no significant increase in PSA over the study period. What about the effects of exogenous testosterone on the normal prostate? What do we know about that? Well, there's some studies here looking at, well, first of all, I should say the historical basis of concern for all of this, of course, was the initial experiments by Huggins and Hodges, who took a small group of patients and reduced their testosterone to castrate levels and caused prostate cancer to regress. And of course, that's the basis of androgen deprivation therapy. And then also gave exogenous testosterone that caused prostate cancers to grow on a basis of acid phosphatase measurements. And since then, it went pretty much unchallenged as to the exact relationship between testosterone and the prostate. So these are 31 healthy volunteers, so normal prostates, no cancer, being given pretty standard doses of testosterone therapy, 100, 250, 500 for 15 weeks. and having measurements out to 40 weeks. And of course, they saw an increase in their testosterone, but significantly no significant increase in PSA. That was published, a second study using supraphysiological doses of testosterone. These guys here having 600, so a very high dose of testosterone for 10 weeks versus placebo. Again, as you would expect, significant rise in testosterone, but interestingly, not much of a change in PSA or in prostate volume. So what about your endogenous testosterone level and the risk of prostate cancer? Here's a large study looking at a pool of patients of approximately 10,000 men, some with 4,000 with prostate cancer, about 6,000 age-matched controls. And essentially, there does not seem to be a increased risk of prostate, or indeed a decreased risk in this particular study between serum testosterone or free testosterone and your risk of having prostate cancer. A new case study looking at large cohort of men stratifying their testosterones into less than 12.5, these 4 bands, actually found a reduction in mortality with a higher testosterone, a reduction in cardiovascular mortality with a higher testosterone, and a reduction in overall cancer mortality with the men in the higher testosterone groups. And a whole load of studies looking here at the link between prostate cancer rates and specifically looking at low testosterone. And this being the largest study here by Shin et al., prospective study, actually found a slight increased rate of prostate cancer in men with a low testosterone versus men with a normal testosterone. This was an abstract from the AUA this year, looking at free testosterone as a marker, or I should say a low free testosterone as a marker for aggressive prostate cancer. So they took 830 patients presenting for treatment with prostate cancer and looked at their testosterone and free testosterone SHBG. And here the sort of grade and stage stratification. And essentially, they split it into quartiles, and the men in the lowest quartile of testosterone, less than 12, had a higher incidence of higher grade disease and higher stage disease, which was significant, leading to their conclusion that a low testosterone is actually an independent marker of high-grade aggressive prostate cancer. Another study along the same theme was looking at men on active surveillance and looking at their free testosterone levels. And essentially, what this study found is that if you have a low free testosterone, that you're more likely to be reclassified and upgraded or upstaged on an active surveillance program. And in fact, if you had a very low free testosterone, the risk of progression was 7 times that of the baseline. And there is some molecular or some lab-based evidence for this, number of in vivo and in vitro studies. Here's an in vitro study looking at concentration levels of testosterone versus the proliferation of LN-cap prostate cancer cells in vitro, and found that basically at normal physiological testosterone levels, there's inhibition, or there is less proliferation, whereas as the concentration of testosterone drops, there's more proliferation of these prostate cancer cells. So that's endogenous testosterone and prostate cancer. What about giving these men with prostate cancer testosterone therapy? Sounds very alien, sounds very contrary to what we've been taught in medical school and FRCSU role, but essentially there's a number of studies now which are contesting this. Here's the SEER database, 52,000 men and 570 of them who had received testosterone therapy, and essentially there was no statistical increase in the rate of prostate cancer or high-risk prostate cancer. Another study here from Europe, looking at 1,000 men, 750 of them had received testosterone, 250 no testosterone, and again, no difference in the rate of prostate cancer in those two groups. What about the risk of aggressive prostate cancer? Here's Stacey Loeb, again, I think a paper fairly recently looking at the Swedish National Prostate Cancer Registry. And they found 284 patients, as well as 1,300 age-matched controls with cancer and no prostate cancer, respectively, all of whom had testosterone therapy, and didn't find any strong link between testosterone therapy and cancer risk, except that TRT patients had a lower risk of aggressive prostate cancer. So these are men who've been treated with with testosterone therapy, appeared to have a lower odds ratio of high-grade prostate cancer in that study. And finally, a meta-analysis, if we need more data, of over 1,000 patients. Again, no significant difference in the rate of raised PSA, biopsy rate, or prostate cancer between testosterone replacement therapy patients and placebo. What about testosterone therapy after prostate cancer treatment? So you've had your patient who's been treated. Is it safe to give them testosterone therapy if they're obviously symptomatic and require it? Here's a study. Again, the quality of the study is now less. There are no RCTs in this particular context. 103 hypogonadal post-radical prostatectomy men treated with testosterone therapy. 49 controls who'd had a radical prostatectomy but were eugonadal. And essentially, the biochemical recurrence rate was 4% in the testosterone group, testosterone-treated group, and 15% in the control group. So again, it does not appear to be increasing the risk of prostate cancer. Post-radiotherapy, again, Alex Pastuszak, who's published a lot on this. Again, not a controlled study, not a RCT. 100 men, again, after brachytherapy or external beam, being followed out for 40 months on average, and with most of them who had low or intermediate grade prostate cancer. And the PSA was not significantly changed in these men, and only 6% of them, according to the classifications, developed a biochemical recurrence, which I'm led to believe is quite low in comparison to usual. And a lot of studies, in fact, of various sizes, looking at all the different modalities, and none of them actually show an increase in cancer rates or recurrence rates of cancer with testosterone therapy following prostate cancer treatment. Finally, here's an abstract, again, from the EAU this year, 800 patients following radical prostatectomy. 150 of them had testosterone therapy post-op, 682 no testosterone therapy, followed up for 3 years, and the biochemical recurrence rates of 10% versus 23% in these two groups. And they, in fact, found that testosterone therapy was, as their conclusion from this abstract, delayed the biochemical recurrence rate. So, again, opposite to what you might think. What about, finally, testosterone therapy in the untreated prostate cancers? Even more nervous now. But here we go. So here's active surveillance. Most of these patients are Gleason 3+3 on an active surveillance program. Some of them have Gleason 3+4, low numbers. And there were 28 hypogonadal men in this series. And as you can see from their PSA, this is their PSA over 60 months. And 32% of these guys progressed versus 44% in the group that did not receive testosterone therapy. So in conclusion, be careful here what conclusions we draw because of the quality of the evidence, but I think it's fair to say that the link between testosterone and the prostate is not a straightforward one. We talked about the permissive element, the saturation model. We can conclude, I think, that low testosterone is common in prostate cancer patients and, in fact, appears to be a risk factor for higher grade disease. There is no current evidence that testosterone therapy causes or promotes prostate cancers. And there's some early evidence saying that in specific groups that testosterone replacement therapy may be safe following prostate cancer treatment, but of course more evidence is required. And here's the EAU guideline on it. RCTs support the fact that testosterone therapy does not change prostate histology and does not increase the risk of prostate cancer, but we need more long-term follow-up. And in terms of offering treatment, offer testosterone therapy carefully, or cautiously, sorry, in symptomatic hypogonadal men who have been surgically treated and are without evidence of active disease and have a low risk of recurrence for prostate cancer and do not start it in the first year following their prostate cancer treatment. And basically, just like most presentations, concluding with the fact that basically there's an RCT in this, and thankfully it's all in hand. 6,000 participants should be done by 2022. An RCT looking at both cardiovascular events, but also prostate cancer incidence in men receiving testosterone therapy. So controversial, I know. I'm tempted to say no questions, but thank you very much. Cheers.
Thank you very much, Roland. We've overrun in time. We have got time for one very quick question. Has anyone got any questions, or should we conclude it there? Do you give prostate cancer? Have you ever had the guts to give a prostate cancer patient testosterone therapy?
Single figures at the moment, yeah, but just starting to do that. I mean, they're few and far between, aren't they? Yeah, the men who need it, if that's the right phrase.
I've done on very selected patients.
Yeah, but we're very, very cautious, obviously. But
thank you very much, then.
Good. So just before you go, there's a very good, exciting session coming on in here on the varicocele, interactive debate between a radiologist and a surgeon. So do stay for that as well. Thank you.